All right. Greetings, everyone. This is Eric Glazer, and welcome back to Bright Spots in Healthcare. We are produced by Bright Spots Ventures. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations across the land, sometimes the globe. Our goal each episode is to identify as many of these bright spots as possible so you can determine if the ideas shared during this episode can be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective way to improve healthcare in our lifetime. If you want access to some incredible guests over the years who share their bright spots and can help you do your job better, help you get promoted, help you to the next level at your organization, I encourage you to subscribe to Bright Spots in Healthcare. Open your favorite podcast app. We're everywhere. Just type in the name of the show and you'll get access to all the great content. And if you're inclined to give us that 5-star rating and maybe even leave a testimonial, that's important because it allows us to reach more of your peers each and every week. Here's an example of a recent testimonial I was super proud of. Quote, I continue to be amazed by the exceptional value I gain from your programming. It's insightful, relevant, and engages me on the deeper level than other content out there. Thank you for consistently delivering top-notch information. I can't recommend it highly enough. That's from Kimberly Ingram, SVP of Clinical Innovation at Excel Healthcare Advisors. Kimber, thank you for that. Now, let's get into today's conversation. Bar set high now by Kimber. It can't come at a more critical time, this episode. Just days ago, as we all know, CMS finalized 2025 Medicare Advantage and Part D rule reminding us, that obviously the regulatory bar for the health plans listening, they're getting higher, especially when it comes to member experience, care coordination, and addressing social needs. So star ratings, adjustments to stricter marketing oversight, expanded supplemental benefits reporting. One thing we know is crystal clear. All of you in the audience that engage hard to reach members, particularly duals, and those with those complex needs, won't just be doing the right thing. They'll be doing the necessary thing to compete in this market. So we're going to talk, how do we adapt? How do we reach members who are traditionally overlooked, isolated, or just very distrustful, of our system? That's what we're going to unpack today with help from some truly exceptional leaders. I'm going to introduce all of them in just a moment, but their bios, if you want to review their background and some of the great experience you're going to benefit from, we'll put their bios in the chat. I want to throw out a quick thank you to our latest partner of the Bright Spots and Healthcare family, Papa. They've built a new kind of care rooted in human connection, delivering scalable in-home social support to vulnerable people across the country. Their Papa Pals model is uniquely relevant given CMS's new focus on outcomes related to health-related social needs. We're going to talk more about them later on the show. Let's get into the bright spots. Let's get going. Our topic today, engaging complex and hard to reach Medicare members amidst CMS uncertainty. I'm going to start, Sheila, I'm going to start with you. Sheila, actually, I'll introduce each guest when they come on for the first time. That'll be the easiest way to do it. Sheila Yahyazadeh, she is the Chief External Operations Officer, super cool title, at CareFirst Community Health Plan in Maryland, part of the CareFirst Blue Cross Blue Shield organization. So Sheila, thanks for being here.
Thanks for having me.
You're welcome. I want to talk about traditional member outreach. We talk about snail mail, we talk about texting just becoming less and less effective. And so how are you guys tweaking or rethinking engagement? And maybe take us inside the CareFirst sort of innovation room. And when you guys realize, whoa, traditional outreach is just not as efficacious as it needs to be anymore. And take us through like what that challenge was and how you approached overcoming it.
Yeah, so thank you for the question. Again, thanks for having me on here, Eric. Much probably like a lot of the audience members here, you probably have a ton of levers for outreach. And if you're anything like me, maybe you're not always checking your mail all the time. And so we've traditionally relied in Medicare space, and specifically in dual, on direct mail. That's, tradition tells us and data tells us that's what was really moving the needle. in the past. And I kind of look at the pandemic as a critical pivot point for getting a lot of those populations that we may have typically thought were not digitally savvy into this digital age. And so, kind of myth busting in our own organization and looking at the data that was out there, and then looking at the fact that we were sending this direct mail, we're not getting the pickup, it's becoming less and less effective. We sat down and to take a look at what tools we've been using. We've been employing text message. I would say that text messages that get sent out, they were falling a little flat, they were a little dull, a lot of unsubscribes, poor feedback, wasn't relevant to them. And so we went back to the drawing board to evaluate what solutions exist out there that could take a little bit of a different approach. And that's where we started looking at a solution with our vendor Relay that delivers messages in sort of a tile social media platform. And so many of us are likely in our downtime, maybe scrolling on our social media while we're watching TV and all the doing this. And so the delivery of the messages that we're now providing to these members come across as content cards. And these content cards are a very easy way of delivering in-depth, rich information within a few, like 3 to 5 reels max. So we sent those out and we started seeing a completely different wave of engagement from our dual special needs plan folks. And as a result of that, we've had better gap in care closure, higher engagement, less unsubscribes. And now we're looking at how to push this and scale it for our entire Medicaid population. So some of the things that we'll get into a little bit later is how do we start to understand the problem, pilot a solution, and then do some rapid testing and understanding to then scale to a greater population.
I love that. So we looked at text messaging, and when you say, like a scrolling media platform, a tile to texting, and you call them content cards, this isn't an app on someone's phone that you get.
It's not, exactly. So we get that. So a lot of times people are, well, why don't you have an app? App takes a lot of data. Not everybody in the decent population or these hard to reach populations, one, have continuous coverage for cell phone data or have the capacity on their phone to do it. And good luck if it works every time, because somebody has to remember their password and log in, which I'll be quite frank, I don't remember mine half the time. So, that is just not effective when you have so many gates for a member to have to pass in order to get to the content. So what we've, in addition to this is delivered via text on a link where they can click through the link in the text message itself. And that provides the content, which is tailored and personalized to them. So it's a very different experience. And I think this goes back to how do we make things a little bit more mobile optimized rather than trying to create these heavier data applications that allows the information to be readily available and easily accessed without having this gate in front of it.
Right. And you're moving out to the Medicaid population, which I love. I look cool. Yeah. You're sort of cloning a bright spot within your organization to another part of your organization, which is obviously super smart. Real fast, because I don't want to fall behind on time here, but implementation, was there any 1 or 2 challenges you could kind of reveal in case someone's going to implement a program like this and maybe avoid a little bit of a hiccup?
Yeah, I think with any health plan, or if you work with anything that has layers in the organization, it can sometimes be a challenge for speed to market. So I think where we are fortunate in our organization is that I'm able to present along with my colleagues, a particular problem with the solution set, and trying to keep that into a manageable population set and manageable cost helps me move a bit faster, so that it doesn't become this like $1 million endeavor, et cetera. Keep it small so that you can get the approval and then move forward. I mean, that's from like an internal piece. From the implementation itself, nothing out of the ordinary other than doing the proper quality assurance checks, et cetera, to try to test these things out. I think what we're trying to look at now is what content resonates the most? How do you test different messages? And then how do you start to refine so that the content really leads to the action that is necessary?
Yeah. Look at you. Sounds like a marketing company. I love it. A good one. So, folks, there's not a lot of things I would call myself above average on, but I do think I am an above average note taker, and I take notes when I prep with my guests, and I take notes during the recording of this episode. If you want a copy of my notes, they're unabridged, unedited, color coded and all. Please take the time in about 25 minutes when I send you another email asking you for your feedback through a SurveyMonkey link. We use this to guide our programming throughout the year and everything we do. It's how we've built this program over the years, 2014 to be exact, to be what it is. So if you take the 2 to 3 minutes to complete that survey, you get a copy of an above average note taker's notes on this episode. And I think it's better than any AI generated notes from this episode, by the way. So,
and Eric, I'm seeing real quick a question, which I'd want to address on the difference of the information being delivered just via like text message, if you will, like a CVS text message. I've gotten those for my flu shots versus a link with a content card. You have character limitations in text messages. And so a link to the content card allows you to, one, more aesthetically design something and deliver much richer content versus trying to include, here are all the things that you might need to do when you join our plan in 1,000 different text messages because you can only deliver certain character limits. So that's sort of the nuance behind that, just as a quick call out.
Nice job. Love that. Caught that before I saw it. I want to bring in Andrew Parker. He is not only the CEO of Papa, but he is the founder. And so Andrew, many plans, invest in addressing isolation and engaging hard to reach members to get their better care. But fewer are able to generate sort of this measurable ROI that's so important, right? Especially for job security. So if health plans are going to be thinking about how success looks like and how to measure it prior to building and implementing, what should they be thinking about? And is there an example of a health plan doing this today?
Thanks for having me and nice to be on the show today. I think there's been an evolution of our product and service, really trying to understand who do we bring the most value for. So Papa typically, 5-6 years ago, we're almost 9 years in now, was brought into health plans because people needed companionship and loneliness and supporting people in the community, which is very much core to who we are and part of our mission. But we've always been in this kind of evolution to say, okay, ultimately, how do we support the right people that we've found that we could drive ROI for and value? And it's really rising risk population, people with health-related social needs, people that are overutilizing the ER. And how do we target our solution to those right people? We had, as an example, and we've been studying Papa for 8-9 years now, and the bar is quite high because, we effectively came up with this concept of companion care from scratch. And so we've been really tweaking the model to understand where do we bring the most value. But there is a health plan that we work with today. They have 24,000 lives in Ohio, as one of our examples. And they just did a pretty big research project with us where they looked back on 3 years claims analysis. And at the same time, they're also trying to understand, did we actually impact loneliness? Did we actually impact unhealthy days? And then how does that translate to cost reduction down the line? And so they originally called us because they wanted to solve loneliness. People were calling their health plan, people were showing up at the hospital, people needed help, care management was getting this feedback. And so they found out about Papa, they partnered with us, and we always felt like we were going to save them money. But if you look back over the course of 3 years, it was actually quite staggering. In fact, people that use Papa 2 or more times within this cohort saw a 19% total cost of care reduction. And so what's pretty amazing is it's actually pretty simple. If you're lonely and isolated and don't have a car and are not engaging with technology, maybe you are responding to some of these texts, but maybe not. How do we really engage those people? And so we've been very successful at doing that, frankly, for one primary reason in the beginning is it's fun. It's engaging. It makes sense. Like, of course, I would love a friendly, caring person to show up at my house and help me or help my parent or help my grandparent. And so after studying it, we've seen that impact. And to break it down a little bit more, like where we saw that impact. So we saw a 60% reduction in member loneliness. We saw a 57% reduction in physical unhealthy days. We saw a 70% reduction in mental unhealthy days. And that ultimately translated to the 19% total cost of care reduction, which was really from, just for a couple pieces of it, 22% reduction in skilled nursing facilities, 18% reduction in hospitalizations, 34% reduction in ED utilizers. And so the data is pretty compelling, but we keep doubling down and say, how do we do better? How do we target the right people? How do we work with partners, our health plans, to making sure we do that? And it's nice that a friendly, caring human can be so impactful to these individuals' lives.
Love that. Does the how Eve, if I could ask you, like, does that measurement approach resonate with how you're thinking about ROI and some of the programs you have in place? And by the way, Eve Gelb coming in is our is the Chief Innovation Officer at Gold Coast Health Plan, and has been in the health plan world for a while.
Yeah, so there's return on investment and there's value on investment, and I think what Andrew's talking about is both. And so I love the founding story of Papa, and I've been following Papa for a while because I was focused on value out of the investment, really, solving for a problem that is really prevalent in our population. And then the pandemic hit and it became a bigger deal, right? So right on time, but highlighting what we need to focus on. But the reality is, and Sheila touched on it, you have to have something that's going to pay for itself in some way, because any organization that is a good steward of the government's money, which is what we all need to be, has to know that we're getting a return. We're using that money wisely. So I think those are great examples of how we do validate. And, people who use the emergency room don't use the emergency room because they say, hey, I want to go to the emergency room, right? They use the emergency room because we don't have a health system that meets their needs in another way. And so, or the health system might meet their needs in another way, but they don't know about it. And so it sounds like what Andrew's talking about is a way to engage people, to help them navigate the complexities in a really human-focused way, not just standing back and saying, well, why is that person using the emergency room? That's not the right thing to do. So I would say great value and return.
That's also a perfect segue to the next question I had planned, almost like you were in my head. So I wanted to ask you specifically about the ED and closing gaps after an ED visit, specifically for your members who went in because of a mental health or substance abuse disorder. Obviously, really tough challenge. Can you share how you guys are approaching that with follow-up and how you're being able to close those gaps and hit those measures that you need to hit coming out of the ED?
Yeah. So thank you. And thank you for the opportunity to be here. And thank you for the concept of bright spots. And I think, as you pointed out, Sheila is taking a bright spot from one place in her organization and elevating it elsewhere. And being here, I get to highlight the bright spots in our organization, which is really about the fact that the organization is incredibly community-based and lives and serves the community in a compassionate way. It's focused on the health of all of our community members, touching 1 in 3 members in our county. So we had a particular problem associated with people who needed to use the emergency department because they were not getting their needs met. And this was particularly related to crises in mental health or substance use. And there are 2 quality metrics in the state of California. They're HEDIS measures. They're very important to plans in California and plans across the country. And those are follow-up after emergency department utilization for mental health and follow-up after emergency department utilization for substance use. And we had started, through our history, not performing well on this particular measure, because when somebody is distraught enough to end up in the emergency room for one of these concerns, sometimes it's their choice to go there. Sometimes somebody else has brought them there. It may not have been their choice to go there. So really getting folks at that point in time to follow up with ongoing ongoing mental health services and substance use services is a difficult thing to do. And so what the team here did is leveraged the state of California's community health worker benefits and an innovative organization called Conejo Health, as well as partnerships with our local hospitals. So we were actually able to place community health workers in the ED so that we were able to engage with people at that moment of crisis rather than a phone call that would probably not reach them. As Sheila was saying, people aren't picking up the phone. They're not answering, they're not looking for our letters or our texts. And so we really wanted to figure out how do we support people in the moment with their needs. And we found that to be incredibly effective because of lived experience of those people who are meeting folks face to face. It's really an important opportunity to connect with someone, to the Papa model of somebody who really cares and is there not as a clinician, but as a human partner to you to support your needs. And we've shown some really remarkable results. We've increased, I'm just looking at my notes here so I don't misquote, but our 2023 measurement year rate for follow-up after emergency department visit for substance use was 28.23%. Our preliminary rates for 2024, we're still in our HEDIS cycle and all of that, is 45.75%.
Wow.
On that, this is the 30-day measure. And for the follow-up after mental health, it was 23.6%, and we're now at 61%. So it's a huge difference. It's not just the community health workers, but the ability of the community health worker to navigate the system and support the member in connecting with that follow-up care. Because it's, getting somebody willing to do it is one thing, and then actually making it happen is another.
So if my math's right, and I was down, it's about a 300% increase.
It is about a 300% increase. Now, what's interesting is probably more of those people than the initial were actually connecting, but it wasn't in a way that we had a line of sight into the whole thing. It wasn't necessarily timely because part of the requirement of this is that it happens timely. And so it enabled us to improve the actual connection rate, but also engage with the endpoint, which is the mental health provider or the PCP if they're going there for mental health services, to capture that data that this was driven from this emergency room. We connected this person, and this person is now engaged in care. So there is a data lift there, but a lot of it has to do with the actually getting the person to engage.
Got it. Great stuff. Hey, before we move on to Sheila, just folks, next week, our episode, we're going to take a little bit of a left turn. We're going to talk about the new physician playbook, and it's going to have a lot of provider executives on, which, sometimes we don't do. We often have health plan. And we're going to talk about AI and how AI is being built into workflows and value-based care programs. And these aren't just folks, our guests aren't going to be talking about what they're thinking about doing. They're going to be talking to you about programs that are actually in place. So if AI, clinical workflow, provider enablement, engagement is important to you, invite you to kind of join us next week, same time, same place. We'll put up a poll. We'll register you since you're on this show, listening right now. We'll register you for next week if you want to come to us for the new physician playbook. So Sheila, hard to reach duals, obviously, most of them probably not connected to primary care, trust issues, all of that. We all know of that. I'd be curious, CareFirst, those of you who don't know CareFirst, you should, sort of greater DC, Baltimore market. Take us through how, what you're seeing in your market and the approaches you've taken to overcome the challenges tied to trust and access.
Yeah, this is a really good one. This system hasn't served folks the way that it needs to serve folks, right? And I think that's part of the reason they're using the ED, as you've said. What's interesting about the Maryland community, and having been born and a native Marylander myself, and now having worked deeply in the Baltimore region, is that our brand has been able to carry a lot of trust and momentum because of the level of community engagement we also have. And that has lent itself so that when we work with partners who are helping us get people engaged into the healthcare continuum, and for example, in this case, right, duals not going to PCPs, we know we need to get them into a professional visit because that's where gap in care closure can begin. we had a roughly, 60% of our duals that had no PCP visits and were going to ED and urgent care. And we wanted to change that. And so we started working with a vendor that had nurse practitioners on staff to help do these in-home assessments. And when they go and do these in-home assessments, they're conducting the gap in care closure review, HRAs, but more importantly, they're addressing a lot of those upstream social needs that lead a member to go to the ED. And so that is sort of the secret sauce of this and all the work that we're doing is how do we get in front of a member so that we can understand what it is they need, address it through the partnerships and public-private partnerships that we have, and then at the same time, start meeting the quality and medical requirements and clinical outcomes that we need to meet as we manage these programs. Challenge, not everybody wants a stranger coming into their home. And so we had to figure out a way to get the word out and start building the connection with the brand as well as our partner in order to make that work. And so it's not, I'm going to show up at your door unannounced. You can't do that with it up in the door. You have to build that trust a little bit beforehand. So there was a lot of engagement. We have community fairs that we do with members where we invite them and we have all of our vendor partners there with us. So they get to do almost like a fair type approach. They make appointments. Our partner can then go see them in the home there. We started doing more education and awareness building with our brokers. So we know that our brokers have a very close connection to the folks that they enroll with us. So we got brokers involved in helping telegraph that message as well. So that getting over the barrier of what is this? Why would somebody come do this? Oh, there's a service that is provided. You can help me get connected to other things that I didn't know I had. Started to become a point of delight and a brighter spot, if you will, for folks that had this service available to them. And again, as we have now seen the success with this piece, we are transitioning to also open it up to a specific cohort of our members on the Medicaid side that we know are sort of falling in that 45 to 64 age range, haven't seen a PCP. How do we get them engaged? What barriers do we need to address? And starting to do some of the same on that side to see how we can get folks into the continuum of care. And of course, as probably many folks on this call know, impacts to risk adjustment, impacts to rates. The work that we do now has a downstream impact years later. So the urgency is always there to get people into care and to address some of those social needs they have.
Yeah, it's amazing getting into the home and what we're seeing, with all the technology flying around us, but just getting into the home, the medical, philanthropic, and business impact it's making. You made me smile because one of the funniest comedy bits I've seen is a comedian by the name of Sebastian Maniscalco.
Oh, I love that guy.
And he talks about how back in like the 60s, people loved when someone knocked on their door, right? And actually, Jess, don't put it in the chat because I don't want people leaving the show, but we should probably put that in our follow-up. And how society's totally changed. When someone knocks on their door now, it's a totally different interaction.
But the one thing I will say, it's kind of interesting, right? Because in some ways we're getting back to basics of visiting at the home, but informed by the technology and the data that helps us do that more precisely. And so this is the marriage of good technology, good data insights, driving you to stratify the population the way that is going to be most effective for you as a plan, to then point your resources in the places that you need to point them and have a human front and face to all of it. So that when people ask me, what are you doing technology? Well, is it a virtual only? Is it tech forward? Everything is underpinned by technology. It should allow us to do the human things better.
That's right. God, that's
music to my ears, at least.
Totally. Yeah. Good, great segue. By the way, you are what your record says you are, and you're moving to Medicaid for a reason. It's obviously working financially. I want to bring you in. You probably could hear your ears were ringing. So, we know how hard it is to get traditional home health resources into the targeted individual homes that we need to, and resources are stretched thin across the country. At least right now they are, and you guys obviously have shown that you could do scale. So rather, I guess I'd want tell me an example of how an organization dealing with urgency and scarce resources were able to sort of solve this problem in a meaningful way. And I know it obviously involves partnering with you guys, but tell me from the like sort of the health plan perspective, how plans are solving this.
Yeah, it's a really interesting thing. The idea of sending someone to the home is actually pretty easy. Like when I came up with the idea of Papa, I was on my couch and like everything we do now, I came up with in like a 5-minute period. Like, oh, we're going to have friendly people. They're going to show up. They're going to do exactly what I want. They're going to be on time. They're going to be, following the rules. They're going to be consistent. But when you start to unpack that 9 years later, we just kind of finally figuring it out. But I think there's a lot that goes into making sure that all works the way you want it to work. And then at the same time, the most important thing works, which is I become, or the pal becomes, as we call our caregivers, the trusted advisor. We had a health plan in Rhode Island, that had this interesting thing happen. We didn't even know about it. We kind of found out about it after. They had access to PAL. They were using it for all sorts of reasons. Their care managers were using it. They were using it post-discharge. But they had this list of like 600 people that were on this kind of like, we need to find them home health aides. And there was 600 people, and they were on the list for weeks and weeks and weeks. And like, none of the local home care companies were answering it because the truth is these people actually needed a PAL. And so someone at the team came up with this idea like, oh, why don't we just see if we can enroll them in Papa? In literally like 3 days or maybe a week, 600 went down to like 5. Papa was able to fill all, 595 visits in literally 72 hours. And really our model is set up to be able to support not on demand, but these like pretty rapid, response needs, and to be able to fill visits that maybe don't require someone to that maybe this person doesn't need 40 hours a week of care. And I think that's what was happening. A lot of these traditional home care companies were saying, well, listen, we can't do it because we want to help people, but we only can staff it if we have the ability to do a full 40 hours per person. These people maybe only needed 20 hours or 30 hours or 60 hours, or maybe 40 hours over the course of 12 months. And so the Papa model really is like these short program hours where someone comes over for 2-3 hours. They may drive you to the doctor. They may set you up with technology. Maybe they'll connect you to one of your other healthcare services. And that was really exciting for us because we feel that we're carving out a big portion of personal care. Personal care traditionally is, ADLs and IADLs, which is like bathing and toileting and, house tasks, tech help, driving. And we actually separated the two. And when you look at it, something like 10 or 15% of people need bathing or toileting. Most people need a PAL. And if you don't need those other things, we should actually better resource manage by bringing in this new kind of care, which we've developed through human connection. So and we've messed this up throughout our journey. I mean, we've learned a lot. Papa has done visits in 7,000 cities in the United States. There's 10,000 cities. And so millions and millions of visits across the country, rural, urban, markets that the whole entire county only has 200 people in it. And so to be able to develop the technology and the solution, which we are definitely tech enabled, to your point, Sheila, like I was saying yesterday, like, are you using AI? Well, it's like, are you using technology? Well, if you're a company, you got to be using the most advanced methods, whether it's AI or whatever comes next, which we of course are, but that's all in pursuit of getting out of the way, actually. Mm-hmm. And just to allow the really magic of what we've developed, I believe, which is the relationship that is built between the member and the PAL. And then from there's so much we could do. We could help them in so many different ways, because when they think of their health plan, they think of Papa, they think of it as an advisor to their healthcare journey.
Yeah. And I said to folks at the beginning, I just want to give a little bit more insight on who you guys are, because I think in light of April 7th and CMS's final rule, I think the greater oversight and transparency in how plans are delivering and reporting on supplemental benefits, POP is more relevant than ever. And just for background, as far as, thinking about an organization that has been there from, the virtual beginning, 2017, they started. They've over 2.7 million companion care visits in over 7,000 cities. That's over 9.5 times more than the cities that Lyft is in. So that's like scale. So they've been doing this for a long time. And with CMS putting the spotlight on how all your organizations have to implement and document the value of supplemental benefits, with Papa's versatility, helping you target specific cohorts, conduct in-home assessments, layer on plan-driven tasks during their visits. It's a scalable solution that's aligned with CMS. around their mandate to address social needs, and it allows you to support stars and stay compliant. So proven, tested, made their mistakes, fixed them, scaled. Papa.com, learn more about them. And in fact, if you want to meet Andrew and just learn more about the organization or meet someone on his team, I'll put a poll up there. I just think he's a good person to just get some ideas from, even if you're not going to use them. Eve, how do you, and I'll make the personal introduction, guys, if you press yes. Eve, how do you think about human connection, and how do you think about human engagement and experience, and maybe give some insights into like how Gold Coast is thinking about that and what your overall strategy is as it relates to human connection?
Yeah. So thanks for that question. And it always, the way that I think about it is what I learned from Doug Eby, who, I don't know if folks know him, but he's at NUCA system, which is like a Alaskan Native health system.
Could you say that name again, Eve?
Doug Eby.
Doug Eby? EBY?
EBY, yep. And
remember, I'm an above average note taker, so I have to ask that.
So he's like a super innovative human being, and I have been able to encounter him at IHI, Institute for Healthcare Improvement, leadership groups and things like that. And he always talks about an intensive human front end that is supported by technology backing, right? And so that's what everybody is doing now. I think Doug has been doing this for many, many years. But, that's really how I like to think about it. And I think that's exactly what Andrew's talked about. It's what Sheila's talked about. We cannot let technology replace the human interaction, but we can use technology to support the human interaction. And that human interaction is the most important thing, and it's the reason why we're here, right? And so it's the reason why we get into the jobs that we do. And, a lot of us recognize that is important, and the first step to human interaction is to try and put yourself in somebody else's shoes. The next step is to talk to others who are closer to those shoes. But the real thing is to engage with the people who are actually in those shoes and listen to them, and treat folks as experts in their own lives, right? Which is why community health workers are so effective, because they have lived experience. And it's why human-centered design and programs that really engage in understanding the human and why the human is acting the way they're acting, and how to support them to improve their lives, recognizing how they define improvement. Like the FUA, FUM measures I mentioned earlier might not be how somebody defines improvement. But, we sort of have this as our proxy for now, right? So we are working really hard to get the voice of the people, to hear the people, to not just try to walk in their shoes, but actually talk to the people who are in those shoes. And being in a community-based plan like Gold Coast, that's relatively easy, but it requires the trust that you were talking with Sheila about, because honestly, we serve a lot of folks who are terrified of that knock on the door, because that knock at the door might be somebody from immigration, might be something else. And so to get in and to get that trust is really hard. So one of the things that we're really doing is coming to the community, where to your local park, which I think, Sheila, you were talking about the fairs, that's where that removes the barrier of, I'm not going to invade your home. I'm here if you feel safe to come where I am, but I'm coming close to you. I'm not invading where you are, but I'm coming as close to you as to make you feel comfortable. And that's work that we've been doing. We've been able to engage with people that would never have gone to a doctor's office, would never have received a mailing, because they don't have a home, where they can receive a mailing. And so I think that human interaction and that being humble, seeing the people we serve as experts in their own lives, recognizing that what matters to them, we probably don't understand enough, and we need to find out more. Being in a community-based plan where people really understand their community, that's how we've been approaching it.
I want to stay in the human connection for a little bit, and I know I want to have Andrew tell a good story, and there's a great story, an example that Sheila has as we sort of get towards the top of the hour here. Incidentally, in our preparation for today, we were looking at a lot of different content. Jessica Tenzer, our producer, and I, and there's a really good insight document. It's like 3 pages long that Papa did author, but it's really more about how trust is a strategic lever for folks in Medicare and how it's working and some of the potential barriers and benefits. It's like a lot of stats. I like to say, whenever I see a USA Today like piece, I always love it because it's quick to the point, easy to read, and I get some value of it. So if you want that content piece, it's entitled Beyond Outreach, Building Trust in the Home as a Strategic Advantage in Medicare Advantage. By all means, click yes in the poll. We'll send it to you directly. I'll send it to you directly because you want more emails from me. That's what you're here for, right? But let's now, Andrew, why don't we get into human connection and the complexities involved in supporting duals and how are health plans able to, you talked about tech, Eve just talked about tech, but you still need that local partnership and that local human touch and in a community-based model. Why don't you tell us a story about how that comes out, at the ground level?
Well, there's so many stories. It's the coolest thing about Papa and our experience, I would say, is I always said everything we're going to do, we've already done, because a lot of it happens, again, between the relationship between the member and the pal. And we really have spent almost all of our effort since we started in really member driven. Like, I'm a pal, I show up to your house, we talk, and you say, oh, can we go to the doctor? Can we go to the grocery store? Can we go to the bank? Can we spend some time at my house? Can you show me how to use FaceTime? Oh, my doctor wants me to do telehealth. I don't know what that is. But what's pretty interesting that happened organically is Papa really is a software tool, but it really is empowering people in the community. And so we have this really great story of this woman named Felicia. She actually got Papa. I believe she was a dual eligible member. I believe she was in Michigan, and she was using Papa. They were calling her, trying to offer it, and she was a little bit scared to it. And we work with our partners to explain what it is. Just like Sheila explained with one of her partners, which is really critical. Like, it is a random call. It could, why are they calling me? But if the health plan's talking about, the call center's talking about, the care team's talking about it. Anyway, Felicia used Papa as a member, and she got maybe, I think, 80 hours for free, and they were taking her appointments to help her out. And then she's like, you know what? Maybe I could be a pal. And once I get back on my feet, maybe I could be a pal. And she was getting a car. We require all pals to have cars. Even if they don't drive the member, we want to make sure they're through a vehicle that we've been able to check and understand that they're qualified to provide that service. And so Felicia gets a car, applies to be a pal, and actually became a pal. So she went from needing Papa to providing support in her community as a pal. And so, talking about a lived experience, pals used to be college kids. Now pals are really more national network of friendly, mostly moms. Our average pal has a personal family caregiving experience. They help their own parent, like my mom, who doesn't want to be a DoorDash driver, doesn't want to be an Uber driver, doesn't want to be a home health aide, but loves helping people, has experiences doing it, and wants to help people in our community. And so the story of Felicia literally gives me the chills. I read it all the time, honestly, because I think it's one of the coolest story. And then what happened is clients are now asking us, oh, can we start promoting in our organization people that need Papa, of course, but people that also want to provide that service, because it is a job. I mean, we do pay people. They're getting paid on average $20 an hour. Some make even more depending on bonuses and different things that we have in our system. But all of this is really powerful because when it's all said and done, humans at our core are, meant to be connected. Every single thing we do, I think we've ignored that for way too long. It's like every single thing we are as people is exclusively for us to connect to other humans, like evolutionarily speaking. And so why did we get so far away from that? And I think now we're talking about whole health and whole person and caring about people in the community. And I think 10 years ago, it sounded like kind of woo-woo, like, community, like, do you really care? And like the data shows, and like we all understand it. And I think COVID put maybe not a bright spot on the fact that loneliness is not this like kind of random thing. It is super powerful, really has a negative impact on people. I mean, the number one form of torture really at a prison is putting someone in solitary confinement. So like, we know it's a bad thing. And so how do we solve it? And I think it's by empowering people in our community to help others in their community, and to do that in a way that's easy to do. We make it really easy for everyone involved. Our pals have to go through very, very, very strict onboarding that's really advanced, and we've learned all these different methods of anomaly tracking and background checking that goes beyond just the basics. But at the end of the day, pairing really, really special people in the community that want to help those that maybe have had a similar experience.
I want to, those who know me or have worked with me know, like, my soapbox is peer-to-peer. And that's why I love that story. It's such a great story about someone who was in need and then became a peer. I always say one of the greatest bright spots in the history of healthcare is Alcoholics Anonymous, and it's all driven by peer support. Sheila, I want to bring you back in and talk about how you're breaking down barriers between sort of the big bad health plan and the member through peer-to-peer, and maybe tell us how that's working for you.
I'll give a step out of a wrap, Eric. We are, one of the things that Andrew was saying, which kind of, and I'll wrap into this story and sort of creating member ambassadors to these different programs, which we've actually observed as well. So we've got members that go through some of these peer programs or other programs that we have engagement, say, how can I get to be a part of this? Can I volunteer? We've even ended up hiring some of members into these different vendor partnerships, which I think tells a very interesting story in light of the current context around economic mobility and being in the community and what creating community can do to lift people up. So that message for me really resonates. And I think it's such a powerful one as we think about all these different engagement avenues and what we're actually creating and doing within society to strengthen the fabric and then strengthen the health and well-being of others. So the story that I'm going to share is also one of my favorites, one of many favorites. Working through sort of a peer-to-peer approach. So we really wanted to get into a few counties. We're statewide in Maryland, but we wanted to focus in on a few counties. And once again, we started on the Medicaid side this time. Medicaid side has challenges, again, with getting people into this PCP. Our population skews a little bit more on the childless adult side. That is shifting. But how do we get in front of people? How do we start creating sort of neighborhood peer groups? And so we're working with a partner on that, who helps us orchestrate those community connections. And in this particular scenario, they had reached out to a member of ours, inviting them to lunch. It was a sort of health education group meeting in their neighborhood. Our member was reluctant, didn't really feel up to it, had been really suffering from depression. And they said, well, why don't we arrange a ride for you? Why don't you come out and see if you like it? They decide to go out. They get to the event. They're sitting in the corner. They're observing. When in that moment, walk in another group of ladies. And it so happens that these ladies were cousins, family, that they had not seen each other in over a decade. And, I didn't think we were in the business of family reunions, but here we are. And so that's the power of connection. That day, she left with her family that she had not seen in all these years, who happened to be on our plan, who happened to be in the neighborhood. And the smile that was on her face that was conveyed to me and the team and just reading the story was unbelievable. How does that relate to healthcare? Well, I hope that most folks on this call understand that direct connection, but I'll say clearly, your ability to create strengthened relationships and impact somebody's mental health and their view and outlook on life changes everything about what they think is possible for them, how they might interact with others, what they start to do and take action on. And that is so, so very valuable. And so I love that family reunion story. We have a few others, but this partner in particular, what I like about the approach, and I'm going to quote them because I can't take credit for this quote, but I love it dearly. It's the concept of, in Middle Eastern culture, chai before business, or in the case of this particular partner, coffee before colonoscopies. So I'm not going to cold call you to, hey, go get your colonoscopy. I don't even know you. Why are you calling me? Click. They call in or they meet with folks and they say, how you doing? How can we help? What do you need? What's going on in your life? and start to build that trust coefficient. And so by association, us being embedded in the community, and I love what Eve said, right? There's a beauty in being part of a community plan that is so embedded with partners from both the philanthropic side, a private side. It creates a completely different dynamic and perception of what the member has access to and what we can do to wrap around these members. So I really believe in that, build the trust up first, get to know me before you ask me to do something. And we've had a lot of folks that come through there that end up wanting to be ambassadors as well.
I have a follow-up for you too, Sheila, because I want to get sort of a sense of I hear about these programs all the time, and then I think execution is where people get stuck. So I want to ask you a follow-up on that. Before I do, two PSAs. One, that survey that I mentioned has already landed in your inbox. So go to your inbox while you're listening right now. Give us that feedback. You get a copy to my above average notes. Appreciate it in advance. Bright Spots Ventures, which I talk about all the time, our mission is to create these authentic connections that drive innovation and deliver results, not like Papa does or like the peer-to-peer program does, but within all of you, leaders in healthcare, collaborating. And so to that end, I just wanted to give everyone a quick heads up that we're launching a Medicare Advantage Leadership Circle. It's for those responsible at health plans for product performance and P&L of an MA product. It's a brand new form. It's exclusively for those M&A P&L owners. It's peer-to-peer, collaborative. We're going to share strategies, stay ahead of policy changes. April 7th, we're going to cover all that stuff. We've got a whole agenda planned for 2025 around adopting to the final rate notice, strategies for duals, age and retention, risk adjustment, and new supplemental benefit reporting requirements. We are limiting participation to one health plan per region, so members can speak freely and get real insights without competitive overlap. We're going to be meeting every other month. It's going to be co-moderated by Dawn Adravalsky. She's formerly the VP of Medicare Independent Health, perennial 5-star plan. She's the one that's in charge of making me look intelligent. We already have 4 members signed up. We want to add 4 more before our first meeting in June. So, and there is a modest membership fee of $3,000 a year. Jess is going to put a application, a survey, just your name, title, company. If you or someone on your organization wants to receive more information about this, you could just click on in the chat the link to the registration, which is via SurveyMonkey. If you're not a health plan, but you want to learn how to form senior councils, leadership groups that we do at Bright Spots Ventures, and you just want to talk to us about how we do it, or maybe even talk about collaborating on one, happy to set up a call with you. We could put up a poll for that. So Sheila, going to you now, you've layered on these multiple strategies, in-home assessments, peer support, the digital reels at the beginning. What have you learned about sequencing these? What have you learned about how things could fall through the cracks? And overall, just you could provide the audience with how does CareFirst do it? Why are they able to come up with the idea and then execute and just implement these things where I think a lot of people talk about it, but find it really hard, have all kinds of headwinds to adopt a new solution provider like Papa into their ecosystem? How are you guys?
Sure. Yeah, I'll take that last one first, and then I'll kind of go into the how everything integrates together. So we do have an innovation and incubation arm that is called HealthWorks. And myself, I work very closely with them on a monthly basis just to vet where we are internally, right? What problems are we seeing? What solutions might I need? Can you do a market scan? Who's out there doing what? And they'll bring to me, or sometimes I get, most of the time, a lot of vendors that come to me directly as referrals to say, hey, we have a solution here. We do a lot of vetting and a lot of due diligence to see and understand who the right partner is for a problem we're trying to solve. In addition to that, we don't bite off more than we can chew. So I mentioned pilots. Fail forward, fail fast. It's a way for us to understand and learn and iterate and not make such a large financial commitment without knowing what results we're actually going to be getting. And so we sincerely appreciate when vendors and partners can come to us with Milliman studies. Those are usually the best ones where we can quickly understand, oh, I see what you did there, and test out the ROI. But sometimes that's not always the case. And as a community plan and partner, we also are invested in sort of building some of the infrastructure. So it's a very collaborative effort with some of these partners. So we have an innovation arm. We've got a team that's specifically focused on program transformation that is looking across the board. My team, especially looking at end to end, where can we put in some engagement pieces? How does this tick and tie together? And then the second part of that is, how are you connecting the dots? Because vendor A, do they know that vendor B is doing something similar? How do we cross-pollinate? So we actually get these partners to come together and talk to each other. We make sure that everyone is informed of the benefits and all those things and start to connect the dots and do some handoffs. So that is something that is a work in progress for us. We're refining that as we go along here. I can't say that we are, 100% there yet, but we have seen that when we have these partners working in concert together, much more effective. The handoffs are better, the engagement is better. There's a trust sort of that happens in the handoff of, oh, this is also available to you. Wow. And we're trying to put that in a comprehensive package under our, CareFirst brand of programs. And then the last thing I would say, when you can reduce layers in your organization to get through some of these things, you're going to have a lot of success. And I think that this speaks to the culture of CareFirst and really wanting to drive innovation, transformation, and really back to the mission of access, quality, affordability. That is what we're, really core in doing and core to us over top of all the community work that we have in place. So it has to be something that is ingrained within your organization of a practice, and then making that a discipline and helping others understand how to put that into place in the different divisions too.
Wow. Great stuff. Picking the right partner, pilot and fail forward fast, team tasked with program transformation to lead it all, Millennium Studies, Milliman Studies help, integrating the partners with each other and reduce layers to drive innovation. I think I got it all. Maybe.
You got it.
That's above average. All right, Andrew, last question here, 3 minutes. I know we talked about measurement and outcomes earlier when you mentioned 3 times top of PAL, three or more. If they see a PAL 3 or more times, we see utilization and costs go in the right direction. How do you get that level of insight, and what can other plans learn from your approach to tracking real impact?
We think studying the impact is incredibly important, and we've been doing it literally since day one. And it's a challenge actually to study things, especially in this industry, because of the structural approach to Medicare Advantage and Medicaid. But we've done our best to figure it out. I think there's always debate on, like, was it us? Was it not? We spend a lot of time trying to work with partners, clients to figure that out. I think we're uniquely positioned because we know things are us because we're with them. We have GPS data. We're tracking the activities, and it's not just an assumption that causation versus correlation type of a situation. But that said, we also look at claims data. We don't use Milliman, we use Wakely. Though both are great. We think Wakely is also good. And we actually many times will have the client send the claims data to Wakely, and Wakely will do the analysis as a objective third party and then share that data back with us. And the client. We've also had many clients do analysis on their own and say, hey, we've been studying PAPA. We didn't really talk to you about it, but here's the impact. And literally every study shows we save money. And they show like 17% total cost of care, 19% total cost of care. They show readmission reduction if that was the focus. And again, I think a lot of it was what we always assumed would be true. I think, we all recognize the reality of, people need help and you're helping them. You're probably going to help them. And when you help them, maybe they're going to be less costly and they're going to be more engaged in their healthcare services. But now we're spending a lot more time to get better and better. So what I would say with health plans is, let's be partners, let's pilot, let's test, let's figure it out. We're happy to do that. I always say, if it works small, it works big. And that's kind of what we've been able to do to scale across the country. We're really open to meeting with partners. We're very transparent. Our product is highly configurable. We could essentially create a budget. We could do it as a benefit. It could be a quality program. It goes towards medical loss ratio. We are very sophisticated, but also recognize you all are very sophisticated. So we'd love to hear from you and learn from you on different ways to go about it. But we're open to partner. We're available across the country. And I think we're very happy. I know we're very happy to work with you to prove our value and not just, hear me saying it's great, because of course I think it's great.
Thanks. Good way to close. I want to thank our guests. They worked hard on this. They had to spend time with me ahead of time. They were great. Thank you all. For all of you listening, thank you for tuning in. We do not take the time you spend with us ever for granted, especially during the day when the Masters is on. We hope you use the bright spots shared today to inspire your thinking and enhance your company's overall approach to improve healthcare for all of us. We produce this show for you. So remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.